Lung volume reduction surgery for emphysema, a comprehensive guide. Pathophysiology of emphysema. Emphysema is a progressive, irreversible obstructive lung disease characterized by the permanent destruction of alveolar walls and the enlargement of air spaces distal to the terminal bronchioles without significant fibrosis. This destructive process leads to a cascade of mechanical and functional derangements. Loss of elastic recoil. The breakdown of elastin in the alveolar walls causes the lung to lose its natural ability to recoil and deflate during expiration. Airflow obstruction. The loss of radial traction on small airways causes them to collapse prematurely during expiration, increasing airway resistance. Pulmonary hyperinflation. The combination of air trapping and loss of elasticity leads to pathological overinflation of the lungs. This is measured by an increase in residual volume, RV, and total lung capacity, TLC. Mechanical impairment. The hyperinflated lungs push the diaphragm downward, flattening it and placing it at a severe mechanical disadvantage, reducing its force-generating capacity. The chest wall becomes barrel-shaped and the inspiratory muscles become inefficient. Autopeep, intrinsic positive end expiratory pressure, develops, meaning patients must generate a significant negative intrathoracic pressure to even initiate inspiration, dramatically increasing the work of breathing. Gas exchange abnormalities, the destruction of the pulmonary capillary bed and ventilation perfusion, VQ mismatch, lead to impaired oxygen transfer, hypoxemia, and, in advanced disease, carbon dioxide retention, hypercapnia. This pathological cascade results in the cardinal symptoms of emphysema: progressive dyspnea, severely decreased exercise tolerance, and ultimately, respiratory failure. Chapter 2. Treatment Landscape for Advanced Emphysema 2.1. Maximal medical management. The foundation of treatment includes long-acting bronchodilators, inhaled corticosteroids, supplemental oxygen, pulmonary rehabilitation, and smoking cessation. For select patients, LVRs or transplant is considered when medical therapy is insufficient. 2.2. Lung transplantation. Considered the gold standard for end-stage disease, transplantation offers the potential for complete reversal of pathophysiology. However, its utility is severely limited by the profound shortage of donor organs, significant post-operative morbidity, for example rejection infection, and high mortality rates, making it an option for only a small fraction of patients. 2.3. Lung volume reduction surgery, LVRS. LVRS is a palliative surgical procedure designed to resect the most destroyed, hyperinflated portions of the lung, typically 20 to 35% of the volume from each upper lobe. The goal is not to remove all diseased tissue, but to restore a more normal mechanical advantage to the respiratory system. Historical context: first attempted in the 1950s but abandoned due to high mortality. It was successfully reintroduced in 1993 by Dr. Joel Cooper at Washington University, leveraging techniques from lung transplantation, particularly single lung ventilation. The NET trial, the National Emphysema Treatment Trial, 1996 to 2003, was a landmark randomized controlled trial that definitively established the efficacy, safety, and most importantly, the precise patient selection criteria for LVRS. It remains the foundational evidence for the procedure. Chapter 3. Patient selection for LVRs. Appropriate patient selection is the single most critical determinant of success. Approximately 80% of referred patients are deemed ineligible. 3.1. Clinical and physiologic criteria, indications. Diagnosis: severe debilitating emphysema despite optimal medical therapy, smoking cessation, mandatory abstinence for 6 months. Pulmonary rehabilitation: must complete a rigorous preoperative program. Pulmonary function tests, PFTs, FEV1, between 20% and 45% predicted. RV, 150% predicted. TLC, 100% predicted. DLCO, 20% predicted, typically 80%. Arterial blood gas, ABG, PaCO2, 55 mmHg or 50 mmHg at sea level. PO2, 45 mmHg on room air. Exercise capacity, post-rehab 6-minute walk distance, 500 feet. Cardiovascular, acceptable cardiac risk, no significant coronary artery disease and no pulmonary hypertension. Mean PAP, 35 mmHg. Systolic PAP, 45 mmH. 3.2. Anatomic criteria, the key predictor of success. Ideal candidate: heterogeneous upper lobe predominant emphysema with significant hyperinflation. These patients derive the greatest survival and functional benefit. Contraindication: homogeneous emphysema or non-upper lobe predominant disease. 3.3. Absolute contraindications: homogeneous emphysema distribution. FEV1, 20% predicted, or 15% if age 70. DLCO, 20% predicted. Pulmonary hypertension, mean PAP, 35 mmHg. Current smoking, significant comorbid illness, for example, heart failure, cirrhosis. Previous chest surgery with pleurodesis. Exercise O2 requirements. 6L-min to keep SPO2 90%. Inability to participate in rehabilitation. 3.4. Preoperative workup high-resolution CT, HRCT, essential for evaluating emphysema distribution, heterogeneity, and excluding other pathology, for example lung cancer, bronchiectasis. Quantitative perfusion, VQ, scanning, helps identify target areas with the worst perfusion, and therefore the least functional contribution. Cardiac evaluation, echocardiogram, stress test, and cardiology clearance are mandatory. Chapter 4, Surgical Technique and Postoperative Management 4.1, Surgical Approach, Bilateral Video-Assisted Thoracoscopic Surgery, VATs. The current preferred approach, it involves 3-4 small port incisions per side. Benefits include less postoperative pain, shorter chest tube duration, and faster recovery compared to sternotomy. Median sternotomy, a historical approach now less common. It allows for simultaneous bilateral access but is more invasive. 4.2. Key Technical Principles 1. Inspection. Meticulous examination of all lobes to identify the target areas, typically the apices, which are the most hyperinflated and slowest to deflate. 2. Resection. Performing multiple wedge resections using a surgical stapler. The staple line is buttressed with material such as bovine pericardium or PTFE to reduce the risk of prolonged air leaks. 3. Volume reduction. The goal is to reduce lung volume by 20 to 35% per side. Over-resection must be avoided to prevent a significant pleural space problem. 4. Air leak prevention. Adjuncts like pleural tents, sealants, or pleurodesis may be used. 5. Drainage. Placement of 2 apical chest tubes on each side before closing. 4.3. Postoperative care protocol. Early extubation. The goal is to extubate the patient in the operating room or immediately post-op to avoid positive pressure ventilation on fresh staple lines. Chest tube management. Tubes are placed on water seal, not suction, immediately to promote lung healing and reduce air leaks. They are managed aggressively for removal. Analgesia. Multimodal pain control, for example thoracic epidural intercostal nerve blocks NSAIDs, is crucial to enable deep breathing and coughing. Pulmonary toilet. Aggressive use of incentive spirometry, early ambulation, chest physiotherapy, and therapeutic bronchoscopy as needed. Medical management, continued use of bronchodilators, avoidance of systemic steroids to promote staple line healing. Chapter 5. Outcomes, Risks, and Benefits. 5.1. Expected benefits based on net data. Lung function, tilde 51% increase in FEV1 at 6 months postoperatively. Exercise capacity, 20% improvement in 6-minute walk distance. Quality of life. Significant improvement in dyspnea scores and overall quality of life measures. Mechanics. Reduced hyperinflation, RV decreases by tilde 30%. Improved diaphragmatic function. Longevity. For the ideal candidate, upper lobe predominant, low exercise tolerance, LVRS provides a significant survival advantage over medical therapy alone. Benefits peak at 6-12 months and gradually decline, typically returning to baseline by 3-5 years. Notably, many patients report subjective improvement in dyspnea even after objective measures have declined. 5.2. Morbidity and mortality. Prolonged air leak. The most common complication occurring in 50% of patients and lasting 7 days in many. Respiratory failure, pneumonia, need for reintubation, tilde 10%. Cardiac complications, atrial arrhythmias, tilde 20%. Myocardial infarction, pulmonary embolism. Perioperative mortality, ranges from 5% to 15%, heavily dependent on patient selection. Chapter 6, Bronchoscopic Lung Volume Reduction, BLVR. BLVR encompasses a range of minimally invasive techniques for patients who are poor candidates for surgery. 6.1. Endobronchial valves, EBVs. Mechanism. One-way valves are placed bronchoscopically into segmental bronchi supplying the most destroyed lobe. They allow air and secretions to exit but prevent air from entering, leading to atelectasis and volume reduction. Critical factor, success is entirely dependent on the absence of collateral ventilation, airflow behind the valve via pores of cone, etc. This is assessed pre-procedure using the Chartis registered trademark system, a balloon catheter to measure flow, and HRCT with fissure analysis, for example, Strat-X registered trademark. Evidence: the Liberate trial demonstrated significant improvements in FEV1, 6 MWD, and quality of life at 12 months. The Zephyr registered trademark and Spiration registered trademark valves are FDA approved. 6.2. Endobronchial coils mechanism. Nitinol coils are bronchoscopically deployed into diseased lobes. They mechanically compress lung tissue and restore elastic recoil by retensioning the parenchyma. Advantage: efficacy is not dependent on collateral ventilation. Evidence: the ReNew trial showed modest improvements in walk distance and quality of life, notably in patients with homogeneous disease. 6.3. Biological lung volume reduction, bio-LVR. Mechanism: techniques like thermal vapor ablation, intervapor registered trademark, or polymer sealant, aeroseal registered trademark, are used to induce an inflammatory reaction and subsequent scar-induced collapse of the target lobe. Advantage: also not limited by collateral ventilation. Risk: can provoke a significant inflammatory response and COPD exacerbation. 6.4. Targeted lung denervation mechanism. A novel catheter-based system, Nuvara registered trademark, delivers radiofrequency energy to ablate the pulmonary vagus nerves running along the main bronchi. This reduces parasympathetic tone, decreasing bronchoconstriction and mucus secretion. Status: an emerging therapy with breakthrough device designation from the FDA based on the Airflow 3 trial. Chapter 7. Conclusion and multidisciplinary approach. LVRs is a well-validated, potent palliative therapy that offers selected patients with advanced emphysema meaningful improvements in survival, exercise capacity, and quality of life. Its success is inextricably linked to meticulous patient selection, predominantly favoring those with upper lobe predominant heterogeneous disease. The advent of bronchoscopic techniques has expanded the treatment armamentarium, offering less invasive options for a broader range of patients, including those with homogeneous disease or higher surgical risk. The management of end-stage emphysema is complex. Optimal outcomes are achieved through a dedicated multidisciplinary team comprising thoracic surgeons, pulmonologists, interventional bronchoscopists, radiologists, anesthesiologists, and rehabilitation specialists working together to tailor the right therapy to the right patient.